Recording in progress. So I hope you can all see my screen and my first slide. So today's topic is treatment-resistant depression and bipolar depression. I know, can you hear me?
We still can't see your screen. Now we're okay, Doc. If you can put it on a slideshow.
Is that okay?
Yes, Doc.
And you can, I'm audible?
Yes. Sure.
Yes. So I will be discussing the first part of the discussion, which is definition of treatment-resistant depression and bipolar depression. I know the second component of the discussion has not been emphasized, yet the treatment is for both treatment-resistant depression and bipolar depression. So I will start by defining treatment-resistant depression. Previously, it has been defined as major depressive disorder in which patients do not respond adequately to at least 2 different antidepressant treatments, typically from 2 different classes over sufficient time. And there's this staging from the Annals of Clinical Psychiatry for the master's students to read through. And you can see that we need to stage because at times the patients are not compliant or they are skipping the medication or the optimal dose has not been achieved or the period has not been, the doctor and the patient have not been patient enough. So you can see stage 1, we'll talk of failure of more than one adequate trial of one major class of antidepressant. You can see class 2, failure of more than 2 adequate trials of 2 different classes of antidepressants. You can read through and you can read more from the Annals of Clinical Psychiatry. I've quoted the journal there. And if I go back to the definition I've put across, the stages, I keep saying that treatment-resistant depression is an elusive diagnosis because you need to have given the patient adequate dose, adequate time, moved from one drug to the other one. And with the side effects, some patients will keep dropping in and out or skip to see what will happen. So it's a very elusive diagnosis. And that's why we have the first stage A, non-responder, defined there, one not responding to one adequate antidepressant trial of either of those classes for 6 to 8 weeks. Then B is treatment-resistant depression, which we will be discussing further. And then there is the chronic persistent depression, which when now we don't treat the treatment-resistant depression, then it now becomes chronic. And you can see it is from the same journal. Basically, we know that major depressive disorder is predominantly a recurrent disorder. We know that 50 to 80% of patients who have received psychiatric care for depression will have at least one further episode. There's a median of 4 episodes in a lifetime, with approximately 20 to 30 of patients with major depressive disorder developing chronic cause of the disease. And that leads to decreased quality of life and costs for treatment and lost business for the patient and for the country. And we know that 35% of all patients with the depression, unfortunately, would end up being non-responsive to at least 2 respective antidepressant drug therapy attempts. That's a big number. And again, I said it's an elusive diagnosis because we are looking at trying 2 drugs for 4 to 6 weeks. And in busy places like Mathari Hospital, where you have to sometimes see a patient a month later or 2 weeks later, or they are seen by a different doctor, it becomes quite difficult. There are risk factors for treatment-resistant depression, including psychosocial stressors, which we need to find out when the patient is not responding. Are there psychosocial issues we need to address? Clinical characteristics of the current depression episode, especially where we have melancholy and somatic symptoms. We could also be missing out other psychiatric and physical comorbidities, for example, the hypothyroidism, or other, like today I reviewed a patient who was a low STH, and we need an endocrinologist on board. There could be non-compliance. We know that because of the side effects and the fact that the drugs have to be taken for at least 2 weeks, 50% of the patients are not compliant. And so before we say it is drug-resistant, treatment-resistant depression, we have to be sure there's compliance. There is also individual differences in drug metabolism. There could be nutritional deficiencies like B12, B complex, and that's why it's important to check for B complex in any patient who is not improving, or even if possible when you're investigating the first time. I think that's a repeat. There could be a comorbid physical illness, other medications or substances of abuse, inadequate treatment of previous episodes, psychotic and melancholic depression. Why should we discuss treatment-resistant depression? We know that it poses a substantial economic burden to the patient and to the employer and to the overall economy. They are twice as likely to be hospitalized compared to the other patients. At least 12% more utilization of outpatient visits. Use of 1.4 to 3 times more psychotropic medications, including antidepressants. And those hospitalized had 6 times medical costs compared to those with non-treatment resistant depression. We have to be careful to be sure that we are talking of absolute treatment resistance, which is failure to respond to one adequate, and not what we have already defined, absolute treatment resistance, and not relative treatment resistance, which is non-response to an inadequate treatment. Now, the other bit of our discussion today, because the treatment we are talking about is also very important in bipolar depression, is bipolar depression. We know major depressive depression is unipolar depression. There is also bipolar depression. And the only way we tell it's bipolar if there is an episode of manic episode for bipolar. Someone could be having depression until the point you give them an antidepressant and they come back with a manic episode. That's the way you know that this is bipolar depression and not unipolar depression. They could have bipolar 2 disorder, depression, which again is characterized by an episode of hypomania with a threshold depressive episode. This is a bit difficult to pick because bipolar 1 usually would require admission and everybody would be able to pick the symptoms. Bipolar 2 depression is not so easy to pick. Then there's also subthreshold bipolar related disorders, including cyclothymia, as well as other specified bipolar and related disorders, which you can find in DSM-5. Differential diagnosis, remember to rule out, or they could even be coexisting borderline personality disorder, attention deficit hyperactivity disorder, or substance use disorders. Remember to also exclude comorbid anxiety disorder or treat, because you could have unipolar depression, bipolar depression with anxiety disorder. You could have comorbid substance use. You could have comorbid personality disorders. You could have comorbid and psychiatric chronic and organic diseases, like even diabetes, hypertension, hypothyroidism. So we need to be able to do the initial tests when we are treating these patients. Again, we know that from a World Mental Survey, bipolar depression, we have a total lifetime 12-month prevalence estimate of 0.6%. And you can see when we break down bipolar 1, bipolar 2, and the subthreshold bipolar disorders, you can see the percentages there. What are the clinical features of depression which will point towards raising suspicion of a bipolar illness? If somebody presents with depression, what will make you suspect it could be bipolar depression and not unipolar depression? Things like symptoms like earlier onset of first episode, depressive episode, that is below 25 years, highly recurrent depressive episodes, more than 5, family history of bipolar disorder, psychotic symptoms, psychomotor agitation, atypical depression symptoms such as hypersomnia, hyperphagia, and leaden paralysis, postpartum depression, very important, and psychosis. Every patient who gets postpartum psychosis or depression, please remember you may need to address or even add on either a mood stabilizer, and if they are coming with psychosis, you add as an antipsychotic which would work for the mood as well, because we know we have antipsychotics which also stabilize the mood. Past suicide attempts, and also antidepressant-induced manic episode. So if you give a patient antidepressant and they develop mania, then that is a pointer towards bipolar depression. When we are choosing the treatment, I know Prof will discuss further on the new product we have in the market, but when you're looking at treatment choice, we need to have the correct diagnosis. That's how we are differentiating between unipolar depression and bipolar depression. Patient's prior response. So mental illnesses, patients will go for second opinion and they will tell you, I was put on this drug, it didn't work, I was put on this other one. And remember, for our patients, we prescribe the medicine, they go and try it out. They are the ones who will report the side effects and whether the symptoms are going, whether there is intolerable side effects. So the patients can actually give you a feedback on previous response. If they have any family members who have had experience with depression, they will also, it will be helpful to know what worked best for the family member. We should also refer to treatment guidelines, which unfortunately the ones we have not for specialists, they are not detailed to capture all the molecules we have. Document if there is any efficacy either elsewhere or here. Side effect profile. Sometimes you have to look at the finances and insurance cover, and especially when you're practicing in a public facility. Patient preference. Sometimes patients will tell you, I would prefer this because it doesn't make me drowsy to go when I go to work, or I prefer this because it gives me sleep, or the other side effects. Now, for today's molecule, we know that from this paper, which is quoted there, adding a second-generation antipsychotic boosts the effectiveness of an antidepressant in treatment-resistant unipolar major depression. And we can also see that second-generation antipsychotics exhibit antidepressant activity either alone or in combination with an antidepressant, particularly in depression with psychotic features. And so when we are dealing with treatment-resistant depression or bipolar depression, we have to look at Do we switch from one class of antidepressant to another? Or do we use a combination of medications such as adding an antipsychotic and a mood stabilizer? Or do we augment with an antidepressant medication or a typical antipsychotic? Sometimes when you look at a patient who has to wait for 4 weeks, 6 weeks, sometimes if you can be able to find the right combination after even the first 2 weeks, the better for the patient, although we are advised to wait for 4 to 6 weeks. But again, when a patient keeps taking the same drugs and they're not improving or they're having side effects, it becomes very frustrating for them. So the discussion will be open for people to give their views and for professor to clarify their experience with the Fluoxetine and Olanzapine with their experience in Pakistan. Now, for us here in Kenya, we've been having challenges of when you decide to combine an antidepressant and an atypical antipsychotic, which dose do you start with? Because you see, if you start with a higher dose than necessary, the side effects, the patient will experience the side effects, too many side effects. And when you start with very low doses, again, the efficacy might not be achieved. So that's why it's good to welcome new molecules. Like we now have a combination of fluoxetine, 25 milligrams, and olanzapine, 3 milligrams. And this will be a safe start for patients who have not responded to the other drugs or for bipolar depression, because at times it is not very clear what dose to start with. And again, this is one capsule which will reduce the pill burden for the patient. And I know Professor and the team will be discussing the molecule further. And in cases where the patient needs another combination, because fluoxetine and olanzapine might, if in case they have a side effect or they react to any of those, we also have various combination, and at least we have an idea of the dosages to start with. We should not forget other treatments and only focus on the medication. We know that psychotherapies are beneficial when combined with the medication. We should not forget ECT, and which is reserved for severe cases and especially ones which need rapid improvement. Ketamine, we have ketamine also in the country, though not in Mathari yet. And the spray is available in other countries. I'm aware it's also being licensed, and in time we can have various options. But not everybody would want to go for the other, like many people might refuse to go through general anesthesia for ECT. Some people will fear that ketamine might be addictive. So again, these are procedures which the patient has to consent, or the next of kin if the patient is not able to consent. The other two, we don't have them yet. And we should also not forget lifestyle modification, regular exercise, sleep hygiene, stress management, spirituality. This morning, there was a discussion on spirituality, nutrition. They are all important in improving mood and overall mental health. And we also have ongoing investigational treatments, which are ongoing, and we are waiting for the results. And I would want to leave it there so that Prof can give us more inputs, and then we can discuss more through Q&A. Thank you very much. I need to stop sharing my screen.
Okay, thank you, Dr. Syengo, for that wonderful presentation. So if anyone has any questions, any comments, please go ahead and put them in the chat box as we go ahead. I think Doc has done a very good job at breaking it down for us from the definition to the symptoms to the risk factors. And I liked that she called it an elusive diagnosis, because with all the things that we have to deal with, from patients being not compliant, or sometimes they can't afford medication, so they don't take the medication for some time and then they come back and it's very unclear whether we had compliance. Situations where we have comorbidities, where we have nutritional deficiencies, like she mentioned with vitamin B complex. Those things can make it a bit complicated to definitively say that the patient you have in front of you has treatment-resistant depression. And so it's good to have those risk factors in mind, so that before you come to that diagnosis, you have ruled out, you have tried to manage everything else, so that you can come up with the diagnosis. I also liked the point about psychotherapy and lifestyle modification, because I think sometimes we just treat the patient with medication, and if someone is still in the same environment, the same stressors, or maybe it's substance use, that's the lifestyle the lifestyle choice that they have. If we don't tackle that side of things, then there's only so far we can go with our medication alone. So remember, a more comprehensive diagnosis and a comprehensive management is important. So next we are going to have a presentation by Dr. Raza Rahman, who will be taking us through the role of olanzapine and fluoxetine combination therapy in the management of treatment-resistant depression. So Dr. Rahman is the former chairman of the Psychiatry department at Dow University, and is currently the dean. Is currently the Dean Faculty of Health and Medical Sciences at Hamdard University. He has vast experience in both academic and the clinical field, and with over 10 years experience in management of patients using the combination of olanzapine and fluoxetine to manage depression. So I'll give Dr. Rahman a chance to share his screen and take us through the next stage of this webinar. So remember, if you have any questions, any comments, please leave them in the chat. We'll answer them as we go along. Thank you.
Thank you, Dr. Stacy, for nice introduction. And I think I have shared my screen. Is it visible to all of you?
Not yet. Yes, now we can see it. You just need to put it on slideshow.
Okay. Basically, Dr. Mutisha has very nicely covered, and he has left no room for me to cover, because she and you have, both of you have covered all the things. So I am going to cover now how to prevent the treatment-resistant depression. I will talk about that. Basically, if you see that depression among the non-communicable disease, the neuropsychiatric illness cover 1/4 of that. And among those neuropsychiatric illness, the major depressive disorder is basically the highest prevalence, 10%. And it is a very prevalent disease, and over 280 million people all over the world are suffering from this. And the point prevalence of this illness is 3.8% of the population. But more important than this is that in the future, it is being predicted that the burden of this depression is going to increase with time. And in the future, by 2030, it is going to be the leading cause of global burden of the disease. With this brief introduction of disease, I would like to share with you the data of Pakistan. This is a national psychiatric morbidity survey. It is still unpublished, and I am a lead person. I am leading this survey in Pakistan. And we have covered 17,773 household patients all over the country. And if you see that the prevalence of depression and bipolar is very high in Pakistan, and you see that it is, 10% current and 17.8% the lifetime prevalence. So it is quite high, and we need to, more careful about this, because the current state of depression treatment in Pakistan is that at least 80 to 90% of the depression can be effectively treated, but more than half of the patient are not being diagnosed. They remain unrecognized, and even who have been diagnosed, only half of them receive any treatment. And those who receive treatment, only half of those are going to receive the appropriate treatment. So you see that that the level of intervention that we have for the patients with the depression is this, and because of this, this depression is a very expensive disease, particularly in developing countries. And if you look at this STAR-D trial, that is basically sequence treatment alternatives to relieve depression, the most comprehensive trial that last was the 7-year randomized control trial that evaluate that the medication and augmentation in 3,671 unimolar patient, OPD patients. And this trial shows that the remission of depression is around 1/3 of the patient remain treated, recovered after first antidepressant treatment. So the challenge basically is that half of those no responders, 1/3 who are not responding, and half of them, those are not responding to first antidepressant, are not responding to the second antidepressant also. Even after multiple interventions, approximately 1/4 of the patient with the depression remain depressed. With the number of failed treatment, the chances of response is going to decrease, and the risk of relapse is going to increase, and that is one of the important cause of treatment resistance in the depression. So the reason of underlying depression has already been discussed, so I'm not going into detail of that. And the concepts which are very important related to treatment resistance is basically non-response. And what is non-response? When the improvement is less than 25% on the scale of the Hamilton depression scale. And the partial response when the 25 to 49% improvement occur on this scale, and response corresponds to improvement of at least 50% on the scale, whereas the remission is the state in which only minimal symptoms are present. So keeping this concept in mind, when the first time antidepressants were developed by serendipity in 50s, so first impression was just people were happy that the drugs are going to respond, and the response is that it is more than 50%. But later on, they increase the bar, and they say the response is not okay. The remission is very important. We need to get remission. But the data shows that the feeling better is not as the doing better. So it means that remission is not enough. If somebody is just in remission, is not doing better, so they further increase the bar that for the free functional recovery. Now they are focusing more, and that any treatment which is good is that treatment which have the functional recovery. And the future, it is going to further increase to the increasing in improvement in quality of life of the patient. So functional recovery is very important because it is being observed that functional recovery decrease the relapse rate. So relapse is more with functional impairment. So if you see that after 6 months and after 2 months, the relapse rate is much higher in those who are not recovered functionally. So the consequence of improper treatment, if the patient is not going to improve functionally, that improper delayed treatment in that depressive disorder increase the recurrence of depressive disorder. And because of this increased recurrence, that is going to lead to alteration in brain biometry and in circuit function. So that is one of the important cause of the treatment resistance, and that the structural changes are going to happen in the brain because of that improper treatment and non-recovery of the functional level. So strategy to handle, how we can handle this, that this biometric changes should not occur, and patient should not go into the treatment resistance. So that can be halted by or reversed by pharmacotherapy or a lifestyle change that has already been discussed. So it is very important that we must early optimize treatment, and that is the key for full functional recovery. Most time we delay in starting treatment, in complete recovery, the more chances that patients are going to, face the treatment resistance. So how we can do that? How we can optimize treatment? So there are 5 steps to optimize treatment. If we are going to adopt these 5 measures, then we would be better equipped to, avoid the treatment resistant in patient. The first key feature for early optimized treatment is early diagnosis and assessment and start treatment. In Pakistan, it is very difficult because we don't have, a native word for the, which can represent depression. So most of the patients in Pakistan, they are going to present with a somatic complaint, and people start, treating them for their somatic complaints and nobody. So this is one of the important challenges that we face, and we need to develop the proper tool and start treatment as early as possible to avoid the biometric changes in the brain. Second, then ongoing monitoring after 2 weeks. First thing is it start the antidepressant as soon as possible, and then call the patient after 2 weeks and to monitor the treatment efficacy and tolerability. And it is being important to note that improvement less than 20% means there is a less chances of treatment success, as the evidence has shown that only 4.1% of such patients achieve remission after 8 weeks. So it means if the treatment, if the person is not going to improve more than 20%, then you need to consider change to the treatment. So 20, but less than 20% improvement on any scale or on clinical observation, that means that this patient is not going to respond even after a longer period. So this is a time that you need to consider the change in treatment. And then third, after 2 weeks, then at the 4 to 6 week, titrate and adjust the dose progress for the improvement. So at that time, 4 to 6, you have to look for tolerability of the side effect, functioning of the patient, quality of the life, and treatment adherence. This is the most important. And for the treatment adherence, it is, guidelines from the WHO, particularly for the developing country, that when you are diagnosing a patient for depression, you must negotiate your diagnosis with the patient. You must tell him that he is suffering from depression. Otherwise, what happens if you are not going to negotiate? The patient is not remain compliant. He is going to ask other people's, the medical store people, and they are going to tell them that these are the medicine for depression, and the patient is not being told about that. Then they stop taking the treatment. So it is very important for treatment adherence. Every patient should be, given proper information about that illness. So patients are going to accept that, and they are going to remain adherent. Then the fourth point, at the 4th week, at the 8th week, evaluate remission. Remission means, as we have already discussed, that the improvement in symptom more than 80% and functional recovery. If these 2 things are very important, if these 2 things are, the patient is remission. And if at the 8th week, the patient is not in remission, then we have to reevaluate the diagnosis and the compliance and the complicating comorbidities. And furthermore, we must review the psychological stress factor and assess treatment adherence. So 8 weeks, if the person is not going into remission, we have to consider and we have to review our treatment strategy then. Then number 5, that the monitor patient residual symptom. This is a very important, that if we want that a recurrence should not occur, then we must monitor the residual symptom, because these symptoms are basically going to increase the risk of recurrence. I'm just going to tell you what are the residual symptoms that we need to consider. So a symptomatic remission with the full functional recovery and return of morbid quality of life should be the goal of treatment. And always assess social, home and occupational functioning of the patient. And if no complete symptom and functional recovery occur, then reassess the diagnosis and readjust the treatment. And now you must be interested in what are the basically these residual symptoms. And these are basically main residual symptoms which determine the recurrence of symptoms. The most important is the sleep disturbance. We need to consider, we need to improve that after recovery. And then the low energy, anxiety, poor concentration and decision making, lack of sexual interest, and pessimism about the future are the few things, are the residual symptoms which remain if after the remission, then they are the strong predictor for the treatment recurrence of symptom, and that leads to treatment resistance. So treatment resistance in the depression is that these are the things that is just repetition. So I'm not going into detail that have already been discussed, and how we can manage. The strategies to manage the treatment resistant depression is switching the antidepressant and combining two antidepressants. But augmentation with the lithium or second generation antipsychotic is the most important strategy for the treatment resistant depression. And cumulative evidence support the addition of, second generation antipsychotic for the augmentation of antidepressant effect of antidepressants. The most guideline of American Psychiatric Association recommend the second generation antidepressants for the partial and non-responders. So combination of olanzapine and fluoxetine is mostly being discussed. And augmentation strategy basically adding an agent to the conventionally used monotherapy and to an existing antidepressant, it provides an advantage of rapid onset of action, no withdrawal, and no loss of partial response. But this one advantage is drug-drug interaction. So comorbidity, deprecap is basically combination of fluoxetine and olanzapine. And the beauty of this combination is that this company has provided this combination in in different doses. So we have a choice, wider choice to select for different type of the patient and different dosage. So efficacy and safety of the olanzapine and fluoxetine combination. This is a 76-week open label study in which Montgomery Aswar's depressive rating scale was used, and the main score noted that was decreased day by day. You see, that was half after 7 point after half week, then 11 point decrease after 1 week, and 18 point after 8 weeks. So this effect was maintained to the end with a mean decrease in Montgomery Aswar's depression rating scale of 22.5 at 76 weeks. So response and remission rate for total sample were high 62.2% and 56% respectively, and the relapse rate was as low as 15%. So this is very important finding of this study. And another study, if you look at that, that is published in American Journal of Psychiatry, you see that the response is, this combination is significantly better at statistically significant, improvement in symptoms of the treatment in depressive disorder in week by week change in the response rate of the patient. And in another study that is published in Neuropsychiatric Disease and Treatment in 2017, that olanzapine fluoxetine combination is better than the monotherapy in treatment-resistant depression. And if you see that the response rate is much better when these both of these are going to be combined. So indication that is one of the very important is a treatment-resistant depression. This combination is indicated for the acute treatment-resistant major depressive disorder not responding to the trial of two different antidepressants of adequate dose for adequate duration. And second is the depressive episode associated with the bipolar disorder, because in the bipolar disorder, we are scared of using the monotherapy because the chances of switching those patients to the mania. So this combination provides a better choice for those patients and to guard that they are not going to shift to the mania if we are going to use this combination. So this combination is indicated for acute treatment of depressive episode associated with bipolar 1 disorder in adult male. So doses and administration in treatment-resistant depression, 1 capsule daily in the evening, generally beginning with 6 to 25 milligram. But depending on the patient, we can start with 3 milligram by 25 milligram. And for the depressive episode associated with bipolar 1 disorder, 1 capsule daily in evening, generally beginning with 6 by 25 milligram capsule, but definitely we can select, you are the better judgment, looking at the patient, you can start with 3 milligram by 25 milligram. So children and adolescent 10 to 17 years of age, 1 capsule daily in a lower dose at the evening time, generally beginning with 3 by 25. But the safety of the dose above 18 milligram by 75 milligram has not been evaluated in clinical studies. So if someone want to use, can use on it, but their the safety has not been, evaluated in any of the trial. So contraindication to use of this combination is contraindicated with the following condition: with a monoamine oxidase inhibitor, with pimozide and thyroidazine. So avoid using this combination with these medications. So increased risk of suicidal behavior in children. So this is a warning. We must consider that there is an increased risk of suicidal behavior in children and adolescents on antidepressant and other psychotic disorder. So be careful while using these medication in children and adolescents. Olanzapine fluoxetine combination is not approved for use in children less than 10 years. So there is no study have been found that it is being used separately. Both of these medication have been used in the children with less than 10 years, but this combination have not been, studied in children less than 10 years. Elderly with the dementia-related psychosis treated with antipsychotic drugs are at increased risks of death. So olanzapine fluoxetine combination is also, because of this risk, be careful while using olanzapine fluoxetine combination in old age. So, but for those who are interested, they can contact the company and to get them detailed monograph about these important things. So I think we have discussed briefly that this combination, but most important that first of all, we must try that the people should not go into the treatment resistance. And the most important thing for treatment resistance is the recurrence, and the recurrence can be prevented by early optimized treatment. And the 5 steps for early optimized treatment is early start of treatment, review of treatment after 2 weeks, because if there is response less than 20%, the patients are not going to respond. Then after 4 to 6 weeks, look for side effect, compliance, and negotiate the diagnosis. And after 8 weeks, the remission should have occurred. That is improvement more than 80%. And after remission, always look for that factors which are going to precipitate recurrence of this disorder. So we stop here because we would like to have more interaction and more response from the participants. and we are ready here to, answer the queries asked by the department. Thank you very much.
Thank you so much, Prof. That was quite informative. I think you've done a good job running through the parts we had not covered. And I think what I have picked up very clearly is feeling better does not always mean doing better. And sometimes maybe we focus too much on, is the patient suicidal anymore? No. Okay, so we are doing good. But they're not able to go to work, they're not able to maintain their social activities, their family and setup is also not working. So doing better is more important. Functional recovery is the aim that we should be getting to. So I read a few questions that I'm seeing in the chat box so far. So I see two questions that are similar. So one is, with the capsule, is it given in the morning or in the evening? Considering we often give olanzapine nocte while we give fluoxetine in the morning. And the second question related to that is, if you give fluoxetine in the evening, will it not interfere with sleep? So, Prof, maybe you can walk us through that. We're used to fluoxetine as a morning dose because it tends to be more activating, and olanzapine is sedating. So, what happens if you give both in the evening?
I think both of these drugs, because fluoxetine definitely is being given in the morning because it has some stimulating effect. But when it is being combined with olanzapine, then the sedative effect of olanzapine, that is causing more, so that is causing more sedation. And if you are going to give it in the morning, then that effect dominate and patient feel lethargic and sleepy in the daytime. So it is being recommended, and a lot of studies have been done about that, and all of those studies point out that it should be given in a evening time after meal. So that is better. So the patient is going to sleep in the night time, and he feel in the morning he remain fresh. So the best time to give this combination treatment is in evening time after meal.
Okay. So another question is, what is the side effect profile that you have seen so far with the combination pill?
From me or from Dr.
It can go to
Leticia?
either of you. From your experience using the combination of olanzapine, fluoxetine, have you seen any side effects? I see another question that says, what's the experience with weight gain? So for olanzapine, most of our patients experience weight gain. Are we still seeing the same effect with the combination pill?
Yes, this is a common complaint we are getting from the patients, that when they are using this combination therapy, their appetite is going to increase. Although fluoxetine have, effect on that cause full on your epigastrium, so appetite is going to decrease. But again, the olanzapine is going to stimulate appetite. So this effect is more, and most of the patient, they are going to, complain that they are gaining weight after this. So that is not because of this drug, because this drug is going to stimulate appetite. And after that, the people are going to take high caloric diet. So we advise them to, cut off, take diet which has low in calorie, take more, salads, vegetables, fruits, rather than, fried foods, avoid that. So that is not going to happen. But definitely, many of the patients who are not to take care of these things, that they gain weight with this combination. But that is, we have experienced that if we spend some time and counsel those patients, then they follow the instructions, and this thing is not going to happen with this patient.
Okay, so that takes us back to lifestyle management as well, not just medical management.
Yes, it's very important when we advise, give this medication beside diet. We always ask them to take regular exercise, because that has its effect. Because of exercise, the BDNF is going to improve, and that BDNF is further enhancing your mood and improving the depressive symptoms. We ask them to maintain their routine, take sleep in the night, early to bed and early to rise. And beside that, third thing, that avoid gadgets as much as possible. So these are few lifestyle management which we used to advise to these patients, and the patients are following, and there is definitely a drastic difference in those who are not following the lifestyle management along with the medication.
Okay. So this question can go to both Prof. Rahman and Dr. Syengo. What consideration can be given to patients with treatment-resistant depression with comorbid hypertension and diabetes? Because these patients, unfortunately, will get very severe side effects, and it will potentiate their comorbidities when we give them olanzapine. So what consideration do we have for those patients?
Okay, thank you. I would say in Kenya, this molecule has been here for about a month, and the combination we have is 3 milligrams of olanzapine and 25 milligrams of fluoxetine. So for the few patients I've had who have been put on it, would preferred it in the morning because the 25 milligrams of fluoxetine was more than the olanzapine. I don't know whether if they are taking it and functioning in the morning and they are alert, the 25 milligrams and 3 milligrams, whether we need now to switch them for the night because the report is they are alert. The side effect profile of what we have so far is predominantly for the fluoxetine because the olanzapine is 3 milligrams only. But we stand guided by Prof because he has had a longer experience on that. We seem to have the pediatric dose yet. Does that mean then if we are to use, we should use 2 capsules for adults? So mine is more of a question. And hypertension, diabetes remain a main problem for all the psychiatric disorders because most of our drugs have side effects. Yes.
In Pakistan, basically, we have experienced that. What is my experience? That the patients are reporting more side effects of olanzapine than the fluoxetine. For example, sleep problem, they are more complaining that they are feeling more sleepy. For appetite, they are more complaining that they feel appetite. This is what I have experienced in Pakistan. And for those patients who's basically have, blood pressure and due to the stress and due to different stressful things, that is going to improve with this. But when patients have the, essential hypertension or diabetes, definitely we need to, if we are going to prescribe, then we have to, give them advice for strict diet restriction and lifestyle management. And if they're not following, then we must use some safer drugs in these conditions.
Okay, thank you, Prof. Just to echo Dr. Syengo's question, she mentioned that what we have here is a 3 milligram of olanzapine and 25 of fluoxetine. So does that mean that for the adult patients, should we give them 2 tablets so that we can up the olanzapine, but will that now make the fluoxetine too high? So do we aim to get the other combination or do we give 2 tablets? That's the question. So for the adults, is 3 milligrams of olanzapine and 25 of fluoxetine sufficient? Because that is the combination that we have at the moment.
Yes, yes. So for adults, definitely, because this 3 milligram have, when it's combined with this fluoxetine, it augments the effect of fluoxetine. And the higher dose will basically need for patients, basically that is another off-label use of this combination. And that is basically in OCD. We are using that, but for that, we use a higher dose of fluoxetine as compared to that what dose we use in depression. So I think this combination 3 milligram is we don't need any other new combination, but this have, and but if the patient not, we have other, but definitely most of the patient they are going to be settled in 3 by 25 milligram.
Okay, thank you. I have another question that says, Sir, you discussed about the STAR-D study in treatment-resistant depression. However, this study has discussed about the role of two SSRIs, which are citalopram and sertraline, but not fluoxetine. So do all SSRIs in combination with olanzapine the same, or fluoxetine is better in combination? Question is for Prof. Rahman.
Yes, definitely. The people have tried to combine them. But there are more studies about the combination of fluoxetine, and because the both drugs were, marketed by one company, that is that one company, because this is a product of that company, they combine that and then they have studied. But people have tried the combination of different antipsychotic with different antidepressants, and they have their effects, but in combination is not available, because in combination this is only in combination there are some other drugs. One is that that with the name of Motival, that have tricyclic along with conventional antipsychotic with low dose. So 2 or 3 combination available, but with SSRIs, the new drugs, novel anti-psychotic combination is only this. Previously, there were drugs few available in which the tricyclic antidepressant, it was still available in Pakistan. The tricyclic and conventional antipsychotic are being combined in combination that are being used. But there is no drug with this new antidepressant and the novel antipsychotic, there is no combination except this fluoxetine and olanzapine.
Okay, so maybe that's something that we will see in the future.
Yes.
Okay. If there are no other questions, I think, thank you so much, Prof. That was quite an extensive discussion.
If you allow me, I can discuss something, more about that. And that is about some off-label use of this medication, that it can be used for it is beside treatment resistant and this bipolar disorder. This combination is very good. My experience is very good in OCD. That is one of the difficult disorder to treat. So OCD, when not responding to higher dose of antidepressant, because we need a higher dose, fluoxetine, 60 to 80 milligram of fluoxetine for OCD. So in this case, the combination of a small dose of olanzapine, that is have a drastic effect. So treatment-resistant OCD do respond to well to augmentation of anti-obsessional medication with this second generation psychotic. So challenges which bipolar disorder, the OCD is very common community with bipolar disorder. So it is challenges as an anti-obsessional drugs may induce exacerbate mood instability. So for OCD in bipolar disorder, along with the mood stabilizer, is a very good strategy that can be used, and we have experienced that in Pakistan, and we get a very, promising result with this. And then another thing that where is the off-label use is challenges of treatment of mixed affective disorder. The mixed affective state is common with bipolar affective disorder, which have more severe illness course, and it is resistant to treatment. So DSM-5, the term mixed episode is replaced by mixed feature, manic hypomanic episode. So mixed state results from the genetic susceptibility in circadian and dopaminergic neurotransmission apparatus. So disturbance in catecholamine acetylcholine balance, which leads to mood fluctuation. So management of is challenging with newer conventional anti-ECD, and so effective olanzapine fluoxetine combination is very effective. Studies have shown effectiveness of olanzapine fluoxetine combination in decreasing depressive symptoms in mixed affective disorder. So these are few things that we need to, I mean, consider beside what we have discussed. So this is very important that we have a very good tool and of combination. And in future, definitely, as you have said, that we are expecting that more combinations will be coming. But at this position, this is very good, and this combination is basically is going to be very good. And another beauty is that it is uh, it is basically available in different forms, not only in single form. Thank you very much.
Okay, thank you. I think reducing the pill burden will definitely help with compliance. So it's going to be good to see what we can do with this combination.
I would appreciate if you just share your experience in Kenya of this off-label use of this drug in OCD and in misaffective disorder.
Maybe Dr. Syengo can answer that. I do not have much experience. Dr. Syengo?
Okay. Yes. So personally, I've seen the patients who have loss and grief and tending to be obsessed with the loss as part of that, because we know grief can move to depression. So those patients who have struggled with obsession of the loss, it tends to work better, because I know previously we have combined drugs like aripiprazole and mirtazapine. Then they have restlessness coming from aripiprazole. So for patients who are obsessed with the loss as they grieve and in depression, I've seen it work. Probably now the off-label of OCD, some aspects of OCD, and also in patients who also struggle with borderline personality disorder. I don't know whether Prof has any experience on that in Pakistan.
Definitely we have, but the borderline personality, many patients who are, difficult to treat. This works very good in those patients, along with the mood stabilizers.
Okay, thank you. I have one more question that's asking, what about pregnancy? Can we give this combination in pregnancy? Is it safe? What has been your experience?
Not about this, but separately, the fluoxetine is safe in pregnancy, and olanzapine is also safe in pregnancy. So first priority should be that patient should remain off any treatment during pregnancy. But if the patient, looking at the safety profile of our both drugs in pregnancy, so this combination is safe, but we prefer that to use single drug in pregnancy, because we have more leverage of combination. For example, I need less than 3 milligram, then we can use that combination. But most of the time we prefer to use monotherapy and not in combination. But if theoretically looking at that, both of olanzapine and fluoxetine are safe in pregnancy separately when are being used, so they are safe in pregnancy.
Okay, thank you for that. I think that was a very engaging Q&A session. You still have some time to ask your questions if there are any, but I would like us to go to the next stage of this. Thank you, Prof, so much. Thank you, Dr. Syengo, so much. That was a wonderful presentation. So today, as you may have seen in our poster, our sponsors for the day are, let me get this right, NabiQasim Industries Pvt Ltd. And they partner here in Kenya with Harleys Limited. And if it wasn't for them, we would not be here. We would not be having this very engaging conversation. We would not have met Prof. Rahman. So I'd like to give Tariq a chance, Tariq Said, who is the country manager, a moment to tell us something about the products that they have, and then we can see if I'll see any more questions and call it a night. So Tariq, please share your screen and walk us through the two products.
Okay, good evening to all. I'm sharing my screen. Let me know if I'm visible.
Not yet.
It's Dr. Tariq, we can see you.
Yeah.
So there's the green arrow at the bottom, share.
Okay, I'm sharing.
Okay, good. We can see.
So thank you very much for giving us this opportunity. My name is Tariq Saeed, working as a country manager Kenya for NabiQasim Industries Pvt Ltd. I take care of several therapies, including psychiatry, neurology, gynecology, gastro, and few other. So thank you, KP, for giving us this opportunity to partner. Hope you can see my screen. I will go my presentation will be brief. It's based on our company profile and introduction of some product, few product in psychiatry segment. I would like to start from brief introduction of our company, NabiQasim Industries Pvt Ltd. So our motto is innovation, technology, and devotion. So NabiQasim Group is a leading business group of Pakistan, having more than 75 years of experience and successful track record of manufacturing and developing high quality finished pharmaceutical formulation, process APIs and cosmetic to the local market and across the globe. We have majorly 5 members of this group: NabiQasim Industries, Surge Laboratories, then Eastern Trade Distribution Companies, Stenco's, and Plastic. Since time is less, we have only 8 minutes, so I have to go very fast. So we have 2 dedicated CGMP compliant manufacturing companies, NabiQasim Industries and Surge Laboratories, producing high quality finished formulation and micro encapsulated APIs. 18 independent marketing teams comprising of around 1,500 marketing professionals, serving more than 65,000 doctors, 70,000 pharmacies, a leading supplier of public and private sector in different countries. For example, MSD Tanzania, SPC Sri Lanka, Ministry of Health Kazakhstan, and we are collaborating with the international pharmaceutical companies for promotion of high-tech biological products in Pakistan. Our quality management, we have different certification, for example, ISO certification from different countries, as we can see here, CGMP certification from Kenya, PPB, then Tanzania, Uganda, and so on. We have very high annual production capacities for tablets, syrup, prostaglandins, injectables. We are fully equipped CGMP compliant lyophilization section based on latest technology to manufacture bulk scale freeze dried lyophilized infusion. While in NabiQasim, we also do micro encapsulation of API through latest German technology at its Surge facility. Contract manufacturing, at both NabiQasim search plant for leading national and multinational companies. Lyophilization, we produce injectable esomeprazole, omeprazole, vancomycin. Then we also have test masking technology. Through that, we mask the test of bitter product so that they will be easy and compliant for the patient. We also do contract manufacturing with different companies. In between, we can see here different name. They are very also very prominent leading companies. We are available in more than 40 countries across the globe. And we can see some of the countries like Tanzania, Uganda, Sri Lanka, Russia, Afghanistan, Kenya, Tajikistan. Our main products, the flagship products are these one, which are also available in Kenya. Like we are also producing dinoprostone, which is available in Kenya. This acetyl cough syrup is also available. Then we have clean enema, which is #1 enema. In Pakistan, even in Kenya, we are #1. And then we have Clospas Fibro as well. In psychiatry, we have these 4 products available in Kenya currently. So we have Dapricap in liquid form, which is fluoxetine. Each 5 ml contains 20 milligram of fluoxetine. So for those patients who have difficulty in swallowing the medication like capsule or tablet, mostly in old age and some adolescent, they are unable to swallow the capsule or tablet, we offer Dapricap liquid. So 1 teaspoon of 5 ml is equal to 20 milligram of fluoxetine. So we are providing another option for such patient who cannot swallow the medication. Then we have discussed in detail, and I'm thankful for Professor Raza Rahman and Dr. Catherine Syengo and Dr. Stacy about the detail about this Codapricap, which is a combination, though it is a new product into the market, but in other market, this combination is available. Currently, we have 325 milligram available here, but very soon, we are also getting 625. So in next 2 month time, we are under registration, we will have 625 as well. And then we have Startup Memantine for Alzheimer cases, and then we also have Espramcit, Citalopram. Those 4 brands, they are easily available here in Kenya on all leading pharmacy. So anybody who want to patronize or prescribe those products, it is easy to get for your patient. So due to the time, thank you very much. And from my side.
Thank you so much, Tariq. That was good to us, for us to know what is available and what's coming. So once again, I'd just like to thank everyone. Thank you, Tariq, for your presentation, Dr. Syengo, for your breakdown of the treatment-resistant depression. And what I took from her is, let's take our time and be thorough before we label a patient as treatment-resistant. Make sure you have gotten done away with all the other risk factors. And from Prof. Rahman, remember that feeling better is not doing better. And so you should focus on early optimization of treatment and get full functional recovery. Also, Dr. Rajab, thank you so much for coordinating this wonderful team today and for the good work you're doing with the CMEs. I can see this there every week there's a CME we are attending. So thank you so much for your good work. So I'll see you everyone in the next one, and have a good night.
Thank you very much.
Good night, and thank you.
Thank you.